Um, okay, good to start.
Yep. Welcome. We're going to get started.
All right. Good evening, everyone. My name is Alexis Shavy, and I am a senior academic advisor at Grand Valley, and an advisor in the College of Liberal Arts and Sciences Advising Center at Grand Valley. You may have met my colleagues this evening. Kayla and Diego are also advisors in our office. So we welcome you to Grand Valley and to the space. Just a little bit that we'd like to let you know. This building, the DeVos Center for Interprofessional Health, opened in May of 2021. It is the third Grand Valley's building on the Grand Rapids Medical Mile, and it features classrooms and interactive laboratories equipped to promote interprofessional team environments. Tonight's event, the Your Health Lecture Series, is a unique educational partnership between Grand Valley State University, Grand Rapids Community College, and Michigan State University College of Human Medicine. The goal of the series is to feature physicians, researchers who can speak on a wide variety of topics of interest to the public. Earlier this evening, tonight's speaker met with pre-med students from GVSU and GRCC. Additionally, the pre-med students had the opportunity to have roundtable discussions with MSU College of Human Medicine students. So thank you to Dr. Behrmann and to our medical students for making this network opportunity available. I'd now like to introduce Mark Grebe, Director of Communication and Government Relations from MSU, to provide a little bit more information about tonight's speaker.
Thank you, Alexis, and thank you all for being here this evening. I do want to thank Grand Valley State University for hosting the event in this great facility. This lecture would not be possible without the co-sponsors of the event, Grand Valley State University, Grand Rapids Community College, and Michigan State University College of Human Medicine. This is the 12th year of the Your Health Lecture Series event at Grand Valley State University, and it's the 10th year of this partnership with Grand Rapids Community College. This year, as we have in past years, we combined our efforts into one event due to the unique partnership we have through the Early Assurance Program agreement between our three schools. Grand Valley State University and GRCC students are eligible for early admission to medical school through this program. GRCC students have pathways to the College of Human Medicine, both through Grand Valley State University and Michigan State University undergrad. Now, without further ado, I would like to introduce our speaker for this evening. Dr. Meghan Behrmann attended medical school in her home state of South Dakota at Sanford School of Medicine at the University of South Dakota. She then completed a pediatric residency program here in Grand Rapids through Helen DeVos Children's Hospital and Michigan State University. At that time, she gained interest for caring for the unique needs of medically complex and underserved pediatric populations, including those with developmental disabilities. This led her to the field of developmental behavioral pediatrics and a fellowship program at Seattle Children's Hospital and the University of Washington. During this training, she additionally completed a graduate certificate in maternal child health and fellowship through the Leadership and Education and Neurodevelopmental and Related Disabilities Program, and that is LEND. Dr. Behrmann then returned back to Helen DeVos Children's Hospital and MSU in 2016. She served as the MSU core faculty member in developmental behavioral pediatrics for the pediatric residency program for 7 years. She is now the section chief of neurodevelopmental pediatrics, medical director of the intensive feeding program, and Gerber Endowed Chair in infant nutrition and development, where she focuses her practice on the comprehensive neurodevelopmental care of medically complex children, NICU graduates, and children with complex congenital heart disease through their critical early development years. It is through this lens and her work in early childhood with developmentally at-risk populations that Dr. Behrmann is thrilled to speak about adverse childhood experiences and how what happens early changes lives. Dr. Behrmann.
Actually, why don't we just go to the poll everywhere to begin with?
Yeah.
So. Okay, so thank you for that introduction. Let's see if I can get this on. One thing that I would love is to kind of know who's in the audience. So if you've never done Poll Everywhere before, it's kind of cool. But if you, oh, no, if you can look back at the side and there's going to be 3 different ways that you can get to Poll Everywhere. So if you want to just use the QR code, if you want to text that number, if you want to go to the website, you can do either of any of those things. And then you'll be able to put on there. What I would like to hear from all of you is, what role do you serve that brings you in tonight? So are you coming as a parent, as an early childhood educator, as a pre-med student, as a medical student, as social worker? You know, what is it that brings you in? So we'll see what we get. So while these are coming up here, I'll give you kind of a roadmap for where we're going to go. So obviously, we're going to talk about adverse childhood experiences, or ACEs. So I'll define what those are. I'll talk about kind of the sentinel, really, really critical first studies on ACEs that came out. We'll talk about just some of the outcomes and things that they were looking at there. We really can't look at ACEs and the effect on later health outcomes without using something in public health that we call life course perspective. So I'll talk a little bit about life course perspective, what that is, the different tenets of it. And then that's actually when we get into my favorite part of the talk, which is talking about differential susceptibility to ACEs and to traumas. So in other words, why do some kids weather the storm fairly well and others don't seem to? So the idea too of resilience. And then at the end, we'll end it up, of course, it's not just a doom and gloom kind of presentation. So we'll end it with, what can we all do, right? In all of our various roles. So perfect. Okay, so we've got lots of students, psychologists, some early childhood educators. Okay. Nursing, awesome. I love it. Pre-med, entering. Okay. Fantastic. So a really nice, diverse group, and all people, by the way, all roles that you can use to help kids. So we'll talk about that. Okay, now bear with me. I'm just going to get out of this. Let's see. Let me go. Oh. This one?
Sorry.
No, you're good. Oh, there we go.
You just want to go back to the presentation.
Yep.
There you go.
All right, perfect. So, okay, so there's the agenda we went through. So adverse childhood experiences, they are basically exactly what they sound like. They're negative or adverse experiences that happen to individuals during their childhood. You can see I put kind of the 10 big categories of adverse childhood experiences, or ACEs as we call them, up here on the screen. You can probably think of others that you might think should go up there. The thing is, these represent the ACEs that were identified and looked at in the initial big ACEs study that we'll talk about here. So this is a study that was actually published in 1998, so over 25 years ago, but it is still really just the pivotal work that's been done looking at adverse childhood experiences and their effect on later health outcomes. So one of the things that made this study so powerful is you can see the number of participants. So this was a collaborative study between the CDC and the Kaiser Permanente system, which is one of the biggest medical systems in the country, primarily kind of based on the West Coast and California area. So they had a group of 17,000 adults who they were asked questions about their childhood, about any traumas, or any of those adverse childhood experiences that we saw on the last slide. And then through, because they were all parts of the Kaiser system, then they had lots and lots of health data to look at with all of these adults. So going through some of the findings from this study, first off, and I think depending on kind of what you do for a living, where you're at in life, this may or may not surprise you. ACEs are not uncommon, not uncommon at all. In fact, they're exceedingly common. So this study found that like 64% of individuals will experience at least one ACE prior to turning 16. And then actually about 20% of the population has 3+ ACEs or an ACE score. So they've experienced 3 or more of those adverse childhood experiences. And just kind of looking back, just looking at these, you know, when you can see that a good number of them are sort of fall into that child maltreatment section. So looking at emotional abuse, physical abuse, sexual abuse, significant neglect is also in there. And then we get into things that happen sort of around the child, happen in the child's household. So domestic abuse, household substance abuse, or an incarcerated household member, mental illness in the household, parental separation and divorce is considered an ACE. And then poverty. So we actually know from lots and lots of studies that poverty is essentially the #1 sort of preventable experience that kids go through that causes like the most health difficulties later on. So that's a really big one. So what we also found was, and this again, probably not surprising, is that some groups more than others are more likely to experience ACEs. So we see different ethnic groups. So of course, just non-white individuals are much more likely to experience ACEs in childhood. Our LGBTQ population, it's not actually on here, but women are more likely to experience an ACE within their childhood. And then we kind of you can see kind of getting into that socioeconomic poverty. So below the poverty line, if you're unemployed, if you have less than a high school education. What I want to point out though is that these are trends. These are more likely to experience. Certainly, just being, say, raised in a middle income family or even an upper class family does not mean that you're not going to have an ACE, right? So we see ACEs happen to kids all across the board. It's just these groups, we see them in higher rates. So what are some of the big findings that came out of the study? What made the study so just like groundbreaking and important? So I just highlighted a few of them here. So one of the big things just coming out of this for those of us who practice medicine is that 5 out of the top 10 causes of death for adults could be linked back to exposure to adverse childhood experiences. So adverse childhood experiences contribute and we know are independently associated with this 5 out of the top 10 causes. So we're not talking about like people who, you know, kids who grow up in violence dying a violent death, right? When we're talking about things like coronary artery disease, chronic obstructive pulmonary disease, lung cancer, other types of cancer, liver disease, that sort of thing. Those are the health outcomes that we're seeing. I wanted to put that first point on there because that one personally, when I read it, just kind of stopped my heart. Like that, you know, as a physician, when we're reading through studies, a lot of times you go like, oh, okay, like that finding met statistical significance, but is it really all that clinically significant? So that first sentence up there, that is real clinically significant, right? So those individuals with a high number of ACEs, 6 or more, on average had a life expectancy that was 20 years less than individuals without ACEs. 20 years, you guys. I mean, for a lot of you in the room, that's like almost your entire life. So that's a lot. That is very, very, very significant. For individuals that we kind of think of having sort of like a moderate ACE score in that kind of 4 or more region, 3 times more likely to start smoking and to end up with lung disease, twice as much liver disease. The 4.5 times more depression, that's diagnosed depression. So we know that that number is actually probably way, way higher, which is reflected by the next number. 14 times more likely to attempt suicide if you have had 4 or more ACEs. 11 times more likely to be an IV drug user. So big, big, important outcomes. When we take those odds ratios, so say, you have a 3 times risk of this, and we put it into real numbers, looking across the country, this is what we get. 21 million cases of depression that can directly be linked to adverse childhood experiences. This is all from the CDC, as you can see on the bottom. And the CDC then kind of turns it around, the data around a little bit, and says, okay, if we could prevent, of course we can't, but if we could prevent all ACEs and just nobody ever had any ACEs, what would that look like to our rates of disease? And so you can see here, almost half of depression would go away. A quarter of COPD, a quarter of individuals with asthma, the health risk behaviors. So again, a quarter of heavy drinking, a third of smoking. So these are big numbers. These are really, really big outcomes. What the other thing that the CDC does, because they know how policies work and how policymakers work, is they turn that into numbers and actual dollar signs. And again, this number just like absolutely floored me. So when you look at the burden of disease that we see that comes from exposure to adverse childhood experiences, they estimate that every year it accounts for about $750 billion spent. Like, I mean, does that floor you guys? It floored me. And so then if we think, okay, what about if we could just decrease ACEs by 10%? Like, that doesn't seem like that bad of a goal, right? 10%. We're talking $60 billion. Right? So this is big stuff. This is really, really, really big stuff. And it's the reason why this first paper that was published was so important, just to all of medicine, to all of public health. The other thing that it represented was a significant paradigm shift just across medicine in general, because really what it made us do, or what it should make us do, is to no longer look at our patients and go like point our finger at them, especially our adult patients, and go like, what's wrong with you? Like, why did you make that decision to start smoking? Why did you make that decision to start drinking? And look what's happened to you because of it, right? All your fault, all your fault. So you should just like reverse all those habits in your like 30s, 40s, 50s, and you'll be fine, right? That's not the case. And so it was a huge shift for us to go from that, so the what's wrong with you, pointing the finger at you, to say, actually, what happened to you, right? What happened to you, something that you had zero control over in your childhood that led to these outcomes. And maybe not even what happened to you, but, and we'll talk a little bit more later, what happened to your mother when she was a child? What happened to your grandmother when she was a child, okay? So like I said, we can't look at this and we can't sort of work out the how and the why that we're seeing these kinds of outcomes unless we look at it through life course perspective. So this is just kind of a framework through the public health lens, and really just kind of hammering home that public health is not any longer just who drank out of the well that was infected with something, right? In order to truly understand public health, to understand health outcomes, we have to understand a few things. First off, we have to understand that adults got to be adults like through a process, right? And there's a lot of things that happened in there. So you can see the pyramid that kind of talks about this, so we'll come back to. So the idea of a time course from conception to death, and again, even kind of stretching that out between generations, and then all the things that have happened. So life course tells us that we need to look at these kind of 4 main categories. And so I think this is a nice way to take this and kind of look at some of the research that's been done on ACEs. So starting off with trajectories, this is a sort of a graph or a visual that I actually use a lot in my clinic, and not this particular one from this particular study, but I draw out this type of thing a lot of times for my families of kids in clinic. So as an example, so you heard that I work at the neurodevelopmental clinic down the road. We do all of the high risk follow-up for kids graduating from the NICU, the neonatal intensive care unit. So we see a lot of kids that are born very prematurely, a lot of kids who have complex medical problems, brain injuries at birth, that sort of thing. So when I am sitting down the day before I see somebody, maybe for the first time, and I'm going through their medical records, I'm going through their NICU discharge summary, this is sort of what's playing in my head, is this idea of, for me, it's a developmental trajectory, okay? And so when I'm going through their NICU discharge summary, I'm looking and I'm saying, okay, well, you were born at 23 weeks gestation, 40 weeks is term, so fairly half cooked. That's a big risk factor for you. You were, 475 grams, really, really little. That's a big risk factor. Maybe you were a twin. Do you have a brain injury of prematurity, chronic lung disease of prematurity? All of those things, I know because of what I do, that those are significant risk factors. And so in my head, I'm kind of tallying that a little bit. And then when the child comes to see me, or even before, I'm thinking, okay, my job is to be those protective factors, right? And try to put as many of those in place as I can. Because starting right out the gate, these kids have a lot of things piling up on them. We also know kids with disabilities are significantly more likely to experience ACEs and to experience, in particular, child maltreatment. So when I see that child then in clinic, I'm thinking, okay, so actually getting them here to clinic is one of the first protective factors I can put in place, because it's my job to really watch them carefully, to do a thorough developmental neuromuscular exam, make sure we're catching things early. We'll talk a little bit about like critical periods here, but the whole time I'm thinking like, birth to three, that's when I know I get the best bang for my buck, right? I am sending them to be enrolled in early intervention or early on to these lovely ladies right over here that I work with very frequently, because that's a huge protective factor for them. Maybe if I'm feeling like the parent-child dyad is a little like, oh, I might do some infant mental health. So this is my job basically every day, is I'm thinking about that trajectory and how can I boost that kid up as much as I can. So then thinking about that program, kind of early programming, critical periods, I love this infographic because it really goes through kind of the big mechanisms by which we think that ACEs will contribute to later poor health outcomes. So we know that this is not like a simple thing, right? This is really, really complex, and things happen on different timelines. They happen in different body systems. But just to kind of go through, so if we think about like the shortest time period, the milliseconds to seconds, we know at different points in brain development, so particularly prenatally when the brain is forming, or again, during those first 3 years of life when the brain is developing so rapidly, and those neurons, especially when you're born, your neurons are still very immature. So when I look at the neurologic exam of a newborn, I can tell you that they're not really even moving because they want to. They're moving because they have to. Their brain is very immature and it's very primitive and reflexic, and their brain is telling them they have to move, so they're moving. It's not really a volitional thing. So if a child is exposed to trauma or to a traumatic experience in those periods of time where their brain is growing so rapidly and just so much stuff is happening with their neurons, we know that those experiences can actually change the actual structure of the neurons because of stress hormones or other kind of chemical changes. So, and that happens fast, right? Milliseconds to seconds. The next one, and we'll dive into this a little bit more, the idea of how trauma can change expression of genes. So we all know we're like born with the genes that we have, right? Like this is our lot in life. But environment and experiences has a lot to do with how those genes are expressed. So we'll talk more about that. The letter D down in the bottom corner, again, is my work life, thinking about these really sensitive developmental periods, birth to 3, into elementary school, adolescence, that sort of thing. And then the last two, I want to talk about a little bit more because I think it can be a really sort of foreign concept. And that's the idea of intergenerational trauma and then transgenerational trauma. So this was a study looking at transgenerational trauma that I think was just fascinating. So this was a study where they took a cohort of women in the Pittsburgh area. It's called the Pittsburgh Girls Study, is kind of the cohort that they used. And they took them when they had, and they did this study when they had infants from 3 to 9 months of age, and they put them through what we call the face-to-face still face paradigm. Now, this is something that's been used in a lot of different studies looking at a lot of different things. And essentially what it is all about is that you take baby and mom and put them face to face. And then you put a timer on and you say to mom, okay, I want you to be really like interactive, talk to your baby, sing to your baby, play with your baby, like just like do your thing, right? And so babies are super engaged with mom. It's wonderful, it's beautiful, it like makes developmental pediatricians' hearts explode. It's great. Then though, at the end of that 3 minutes, we say, okay, we want you to look away, look back at your baby and be still faced. So you're not going to interact. You're not going to talk. You're not going to show any emotion whatsoever, which by the way is really, really hard because babies don't like that, right? Like it's quite distressing. So we're going to do that for 3 minutes. And then when that timer goes off, then you can go back to being like your engaging, wonderful self. And then what they're looking at is what baby is doing. So what they found is they then kind of categorized the women into those who had no child maltreatment in their history, those women who experienced child abuse. So this is the moms, but this is not the babies. Women who had experienced child abuse, and then women who had experienced neglect in their childhood. And what they found was really fascinating. They found that across those groups, their babies behaved really differently. And again, this is not, the babies haven't had any kind of maltreatment, right? This is the moms. So what they saw was that for the women who had experienced neglect in their childhood, their babies tended to be very low reactors. So kind of like just meh about things, right? So like, yeah, I'll play with you, but you do the still face thing, like, like I'm like, whatever, I'll just start playing with my toys. That's fine. Like, and then when moms would come back online, again, just really not a lot of reaction. Just, oh, okay, you're back. Like, sure, like, let's do it. Whereas with the moms who were exposed to abuse, their babies completely the other end of the spectrum. So they were extremely reactive. This is a baby that's like, when they're happy, they're really, really happy. And when moms turned off that engagement, they lost their minds. And then when moms came back, some of them, what they really were looking at was the difference, right? That reactivity. So you can see a number of different responses when moms kind of come back online. You can see babies who are a little bit spiteful, who are like whatever, you like totally turned off on me. I'm just going to ignore you for now for a little while. You have babies then that just like are super happy, or babies that continue to be really fussy and like, I can't believe you did that to me. I'm super upset and I'm going to be upset for a while. So just, I mean, it really, really demonstrates that intergenerational kind of trauma experiences and responses. So then naturally, I think all of us go like, okay, like how does that happen, right? Like what on earth could be happening there? So when we think of intergenerational, so just from moms to babies, it actually kind of makes sense if you think about what happens with women's reproductive organs. So women are born with all the eggs that we will ever have, right, in our ovaries. So if you take, so think about then like a newborn baby girl, back that up a little bit, you know, a month earlier, they're a fetus in mom's uterus. So they have that baby, that fetus has all the eggs she's ever going to have inside of mom, right? Who is also inside of her mom. So all of us at one point were eggs inside of our grandmothers. Okay. So then it's actually then kind of not a giant leap to think like, oh, what happens to our grandmas and our grandmas who experience domestic violence, who experience systemic racism, who experience slavery, right? Of course, that's going to affect multiple generations. And there's lots of reasons for that, but this is one of just the really kind of basic reasons. So then the last kind of tenet is cumulative impact. So we know, again, thinking timelines, thinking trajectory, things add up, right? So this is from like wave 2 of the ACEs study, where they just kind of kept going out and getting more and more people. So you can see that a person's risk factor for heart disease kind of like it's going up, but once you hit that 7, 8 ACEs, like whew, you are really skyrocketing, which is kind of what we saw with that one statistic of like 20-year difference in lifespan, right? For me, and what I see, that's kind of the second graph here, is that it's a little bit more linear when we're talking about things like developmental delays. And these are delays like cognitively, social delays, language delays, and really it just marches up the more ACEs that you have, to the point that you can see really if a child has 5 or more, I mean, it's over an 80% chance that they're going to be, delayed in their first few years of life, which then you can see why I'm passionate about this, right? Because these are my peeps. These are the kids that come to me. So as we're looking at this data, I think it's good to remember that these are trends. These are overall trends, right? So then when you see all these little data points, and there is a pediatrician named Dr. Thomas Boyce. And this is what he was kind of looking at initially in his career, was like, what's going on with like all this noise, right? In the studies, like, is this important? Like we see this person way over here on this end who has experienced like 8 ACEs and they have great health outcomes. Like, is that just a total fluke? Again, is that like noise in the study, or is that something important that we need to look at? So, and in general, I think this makes sense to us just intuitively. We know that not all kids respond to trauma, to adverse childhood experiences like others. We know that some kids are just powerfully affected by it, and other kids, again, seem to weather the storm a little bit better. So this is where the idea of differential susceptibility comes in. So this is where you may see me get like super excited and geeky, because I think this is fascinating. So the idea that Dr. Boyce came up with was this idea of kids being on a spectrum from orchids to dandelions. And so if you think about a dandelion can be like, I mean, a kind of pretty weed in the middle of a beautiful like mountain meadow, right? It can also grow and be the same kind of pretty weed in the middle of the highway, in a crack in the highway where there's no soil, and it maybe gets a little like antifreeze, thrown on it by passing cars, right? And then on the other end of the spectrum, you have orchids. And orchids are those that like, you gotta, if you give them their 1.5 ice cubes every like 36 days, you might get it to bloom a second time. But if you throw any adversity at an orchid, like game over, right? They're gonna wither, they're not gonna do well. So Dr. Boyce proposed that, again, these would be maybe 2 ends of the spectrum for kids and for their susceptibility to traumatic experiences and to growing up in stressful environments. And so he first started off in the lab, and they would put kids through kind of mildly stressful situations. So things like, I'm going to drop lemon juice on your tongue. I'm going to ask you to memorize a span of numbers and tell it back to me. So kind of just traumatic or mildly stressful. And then he measured all kinds of laboratory data on basically stress response. So cortisol kind of hormones, he measured heart rate, blood pressure, that sort of thing. And so you can see that in this slide that we have who later became known as the dandelions, who just weren't really affected by any of the things that he was doing. And then on the other end of the spectrum, you've got the orchids, where this is mean arterial pressure, so a measure of blood pressure. So, I mean, their blood pressure was like hitting the roof every time, right, that they were being asked to do something. So then his next step was to take these kind of orchids and dandelions and put them into the real world and look at real world health outcomes. And so for the most part, they found what they sort of thought they were going to find. They found that the dandelions, whether or not whatever kind of environment they were raised in, if they were raised in a really supportive, loving household, if they were in a more stressful kind of household, either way, the outcome they looked at was the number of respiratory infections that these kids got like during a season. So either way, it didn't really matter. They just kind of got like a pretty average number of infections. The orchids, however, in high stress conditions, these were the sickest of the sick kids. So these are the kids that are getting admitted for pneumonias, they're catching everything, and they're getting super sick when they do. So, and those were kind of expected results. What they didn't necessarily expect was that when you took the orchids who were in very supportive, loving environments, they were the healthiest kids. Okay. So they did by far the best, significantly better than the dandelions. So this is just a graph that kind of shows like this is what we see in the real world with health outcomes, is that you have the dandelions who can either be like the best of the best in really, really supportive environments, or the worst in whatever outcome you're looking at in high stress kind of environments. Whereas the dandelions are just not affected nearly as much. So, and we know from lots of studies, this isn't a, it's not an either or, right? And I think all of us kind of immediately start thinking about people we know that are on this spectrum. I think those of us who are parents kind of think like, oh, I got maybe a kind of a dandelion over here and a like real orchid, like significant orchid on this side of things. But we know it really is a spectrum. And so again, we're all scientists. So we think like, okay, what is going on here? And we know we have found since then that there's a lot of things that go into whether you're an orchid or a dandelion or where on that spectrum you're lying. So some of the things we've kind of already touched on, temperament and behavior definitely comes into play here. So orchids, and this is not hard and fast, but orchids tend to be a little bit more the introvert, the shyer kids, the ones that are just more sensitive in general, whereas dandelions tend to be like very extroverted, very confident, that sort of thing, just not real sensitive kind of kids. So then the last one I want to get into a little bit, and that's the idea of kind of environment and genes and how they interact with each other, which is what we call the epigenome, because this is really where this field is going at this point. So this is where we really think like the money is here. And this is the idea that, again, we're all, we have the genes that we have, right? But if you picture your genetic material as books in a library, we know that some are just like readily out on the shelf and like ready to be opened and read and put into action, right? And then there are a lot of other genes that may be put into boxes and like put in a back storage room. And what the epigenome is this is a chain of chemicals, of proteins that sits on top of your genetic material, and it controls what is expressed. So what genes are translated, transcribed, and are expressed as proteins, and what genes are not. So what genes are unpacked from that back room and read and put into practice, and what ones like stay hidden away. And what we know is that exposures, environmental exposures, trauma, lots and lots of basically environment goes into what happens with that epigenome. So this is really, like I said, this is really where the science is going. This is where all the research is going to try to understand kind of this process, because at this point, we know that it happens, but there's still a lot of question of exactly how it happens. Okay, so I'm going to attempt to show you guys a video.
Turned off the sounds.
Oh, okay. Share feed and then.
Just, yeah. And back to the show.
Well, I want to.
Okay.
Here. Well, actually, let's start sharing here.
Yep.
Perfect. So this is a video from the Center on the Developing Child out of Harvard. I put a list of resources at the end of this presentation. This is a particularly phenomenal site. So I would highly recommend it, but I just thought that this video was too good not to kind of show you guys.
Resilience. So, really between two characteristics in the person and the environment in which that individual is developed.
It's really counterbalancing difficult things that child's life. Positive.
There are things on both sides of that scale, experiences of both bad things or good things.
Our genes shape where the fulcrum is positioned at the start.
There are certain genes that make a child more sensitive to the effects of maltreatment or parental neglect or violence.
The fulcrum may start out kind of more towards one side or more towards the other side, and that's going to make a big difference in terms of how much these subsequent events affect things positively and negatively.
Science tells us that experience moves the fulcrum for better or for worse.
Even though we are born with genes, genes will respond differently to certain environmental situations as opposed to others.
What the genes are actually doing are turning up or turning down the expression of chemicals and circuits in the brain and the circuitry in the entire body that response.
When positive experiences accumulate and children learn coping skills that help them to manage stress, the fulcrum can slide, so the scale tilts toward positive outcomes more easily. That's what resilience is all about.
It's always the adults where they want to go is key to providing that relationship that helps to build resilience.
Hey guys. Okay. So I just love that video. And then also Dr. Boyce was on there and he's just like my hero. So I love, he has a TED talk, by the way, it's really, really good. If you ever get the chance to hear him in person, he's really, really good. And I'll show you too, he has a phenomenal book that I would highly recommend. So this is really then the point that we get to where we say like, okay, I'm sort of done being doom and gloom. And now we're to say like, what can we do? right? So we know that adverse childhood experiences are bad, right? So they are probably far worse than we ever recognized from a public health standpoint. So what can we do? Well, really, from everything that we've learned, we learned there's a lot we can do, and there are a ton of places that we can intervene. And if we think about that analogy of the scales being tipped, then it really just from a physics standpoint leaves us with kind of two areas that we can intervene. We can stack the scale in the right direction to get those positive outcomes to kind of come out over the negative ones. And we can also move the fulcrum, right? So just kind of like the video was talking about. So when we think about stacking of the scales, that I'm going to take you back to some of the graphs that I showed you earlier. So the pyramid kind of shows you all these different areas, again, things that happen, things that have to happen in a child's development. This is where I live, is the disrupted neurodevelopment, right? So this is me right here, DBP, developmental behavioral pediatrics. But we know general pediatricians in the medical home, also super, super, super important, right? They can intervene actually at lots of places in this triangle. And especially if they can maintain a relationship with a child throughout childhood, then there's a lot of time too that they can intervene. We know that educators are massively important, right? So I think one thing to think about is you think about one orchid child. And the beautiful thing about orchid kids is that they have like almost limitless potential, right? These kids have the potential to be like game changers in our society. These are the brilliant minds. These are kids that are gonna like go somewhere, do something, be phenomenal parents, right? Do all the good things that we need people to do in society. And you heard on the video, sometimes all that it takes is one really caring adult to intervene with that orchid, right? And to put some kind of safety nets in place to help them out at all these different points. So you can imagine how like one really good teacher absolutely can do this. A good pediatrician that the child feels comfortable with can do this. We know that supports that are put in place in the community to help parents, like parenting classes, parenting supports, maternal child health kinds of resources are also really, really impactful here. Because the really powerful thing we could do potentially with that orchid is to teach that orchid's parent how to be a good parent, right? So this is one thing that like our early intervention providers will do a lot, is they do a lot of parental education, lots of social programming, and then policy change, right? That if we really, really want to do something. The other thing we can do is we can move the fulcrum. And these are, again, it's a lot the same kinds of things because all of this stuff is so interconnected, right? And it gets so complex. But really then, because of that complexity, we know if we just intervene in maybe just even like one place, it just can have this like incredible ripple effect. So here are some wonderful resources. This is a huge topic. Every little portion that I touched on tonight is like, can be a course on its own. So I really did just do that. I touched on it. So my hope was really to kind of pique your interest in something, and then you go and you look into it more. For the students in the room, pediatrics is the way to go. I'm telling you, like adults are just like, and we know like by the time you get to be an adult, like can't do anything with them, right? We can do things with kids. We can make a difference. So pediatrics, way to go. At any rate, all of these websites are really wonderful. And then this is Dr. Boyce's book, The Orchid and the Dandelion. So it's a really, really phenomenal book. As we were talking earlier, it's a terrible Audible book. The narrator is really bad, but it's a great, great book to read. Questions? Yeah. Yes, right there.
I'm just so curious about
absolutely. So phenomenal question. I'll just repeat for those that are online. The question was looking at those categories of ACEs that I showed you from that 1998 study. Would that look a little different now, thinking about things like climate change, school safety, school shootings, that sort of thing? I would also add in there the pandemic. Because, and yes, those studies are being done. People are looking at that, and we're understanding more about just kind of those farther reaching things. So in particular, climate change is absolutely something that's being looked at. And just from a very, very basic level, so areas that are getting essentially too hot for kids to play outside, right? Like that's a big issue. We need kids to play outside. This is a protective factor. So, and then lots of people are very interested in how the pandemic and shutdowns and isolation has affected kids, and especially thinking about those critical periods, because we know that one of the populations that suffered the most during the pandemic was our adolescents, because we took them completely out of all of their social supports, all of their social network, which is massively important at that age, at, you know, just in brain growth and development. Yeah. 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 Sorry, go ahead. Yeah, so another super good question, kind of talking about, so if you have a mother who's born in a different country, a different culture, just a different set of experiences, right? And then comes maybe and is raising a child here in the United States. And what I would say about that is that I have seen studies looking at where moms are coming from like more like violent situations, more, you know, war-torn countries and whatnot. And yeah, we know that that's going to have a multi-generational effect in terms of health outcomes. So really in those cases, then we know that is a vulnerable, I kind of hate that word, you guys, but it's a vulnerable population then that will really want to focus on those protective factors, on supporting that mom. So, and just all kinds of things like did she come by herself? Did she come with a family unit? Does she have the kind of cultural and social support that she needs to help raise that child too? So putting those, that's just a situation, again, importance of putting those protective factors into place. Oh, sure. That's a really, really good question. So probably the biggest thing that I'm sorry, repeating the question. Okay, so what kind of interventions are there for adults where we have ACEs in their history? One of the biggest things, and the thing is, you guys, medicine, like clinical medicine moves like at the rate of a glacier. So we're really like just kind of starting to deal with this. And this is like studies from 25 years ago, right? But one of the things that we know helps is just to ask, right? So you ask about childhood experiences. As an internal medicine doctor, you ask your 70-year-old patient about adverse things that they went through as children. And that will give you a much better kind of perspective in looking at health outcomes. But honestly, a lot of times it breaks down right about there, because these are kind of uncomfortable conversations to have if you're not used to having them. In terms of specific adult interventions, like, you're asking the pediatrician, so like, I just kind of dump all of adult medicine. But, you know, certainly you can just like mental health supports and things like that. So it's going to be a little bit more like after the fact kind of supports to help that. And really you're going to be helping that individual person, but you may also be helping that person to be a better parent, right? Or a better grandparent. So that's where I would say are the best book. Oh, I think you had your hand up first, maybe. Oh, shout out a question. Yeah. So the question was asking about like paternal side of things when we're talking about intergenerational and transgenerational trauma. So it absolutely has an effect, and we know it has an effect on the epigenome stuff. It's just not as direct of an effect as we're going to get from moms because of that, you know, again, being an egg inside your grandma's body kind of phenomenon. But still very, very important.
Yeah, Steve, that was actually my exact question.
Okay. Great. Okay.
What specific examples?
So shifting the fulcrum. So an example of that would be enrolling a child in early intervention, let's say. So and for those that may not be familiar with that, so early intervention, or early on, as it's called in Michigan, is a program to serve kids from birth to 3. It's a program where if you have a child who is at risk, developmentally, socially, whatever, or you're worried about this child having developmental delays, you refer them to early on. They make it real easy in this state. It's 1-800-EARLY-ON or 1-800-EARLYON.org. Parents can refer, teachers can refer, physicians can refer, anybody can refer. And they will reach out to the family. It's completely free. They don't bill insurance. They come to the family's house. They will evaluate the family. Generally, it's a duo team. Early intervention is made up of a lot of pediatric therapists, so speech therapists, physical therapists, occupational therapists, social workers, early childhood teachers. So they'll come out to the house, they'll evaluate the child, and then decide whether the child qualifies for services. And that may be because of developmental delays. It may be because of risk factors. So they have like, I don't know, several pages of medical diagnoses that will qualify a child just automatically for early intervention. And then the whole idea of early intervention is that they work on a parent training model. So we know that like for pediatric therapy, we can, you know, lay hands on your kid and we can do some things, but we're not with them all the time, right? The parent is with them all the time. So sure, we can have them come in once a week and we can manipulate things and do things, but we can also have a huge amount, just a huge impact on their development by teaching the parent what they need to be doing. So I think early intervention is just a beautiful example of kind of helping to shift that fulcrum. And also kind of thinking about, again, like policy change and putting things into dollar signs. We know just, and this has been shown over and over and over again, that for every $1 spent in early intervention and those services from birth to 3, we are saving $10 later in special education costs, because early intervention can actually prevent a really high number of kids from needing special education in school, which is exceedingly expensive. So there's a reason why it doesn't matter who's in the White House, early intervention generally gets funded, because you use statistics like that, right? Which are pretty dang hard to argue with.
So we have one in the chat that, or in the Q&A that's kind of long. So I wanted you to maybe read it straight off, and then we are at time, but maybe this can be the last one.
Okay, I don't know if you guys can
They can
see
see
it,
it,
but
but you'll
yeah,
have
I'll read it for those online. I'm a foster parent who got a sibling group ages 2, 4, and 7. They came from extreme neglect and poverty with addiction, abuse, etc. I've had them for 2.5 years and can see so much of what you're talking about. The 2-year-old has the least amount of obvious trauma, while the 4 and 7-year-olds have a lot more trauma-based behaviors. Is part of that just based on the age where he was removed from the dangerous environment? So many more of his formative years were spent in a safe, loving home. Awesome question. And this would be a very typical kind of scenario that I would see in clinic. We get a lot of kids referred in who are in foster care. So I think important things there is when we think about like critical timing of things, then yes, I would be just in general more concerned about the children who left an abusive household at a later age than maybe the one, and I forget the ages at which they were removed, but the one that was removed when they were quite a bit younger. So just again, thinking too, not only critical time periods, but also that cumulative effect. So the longer that the child is in that kind of traumatic environment, the more we would worry about them. But then we also know that there's so many other factors, right? Like you could have kind of like thinking of dandelions and orchids, like what do you have in that mix of 3 kids? And additionally, I think the really important thing from like foster care and just kind of overall here is that we can't say enough about how absolutely crucially, unbelievably important and valuable it is that these children are now in a stable, loving, predictable, like relatively low stress kind of environment, right? So we can see, and again, for the early intervention people in the room, you know exactly what I'm talking about. We can see a child who is severely delayed when they come into foster care. And once they are just in just some stability for even just a couple of months, we can see massive, massive differences. So there are kids that I see right away where I'm like, this kid is headed for an autism diagnosis, 100%, like nonverbal, isn't interacting with anybody, but I'll never make that diagnosis in that situation because I have seen, sometimes we see those kids back a few months later and like, what on earth was I thinking? This child is not autistic whatsoever because they've made so much progress. So I think that answers that question.
Let's thank Dr. Behrmann. I want to also thank all of you who joined us both in person and online for coming out this evening. Also want to thank our co-sponsors, Grand Valley State University, Grand Rapids Community College, and Michigan State University College of Human Medicine. Also, big thank you to Alexis and her team for hosting us here in this beautiful building. And have a great rest of your evening. Thanks.